pleasure to introduce now Dr. Aly Abdelkarem. He's a professor of urology at Alexandria. He's a fellowship of Manhattan University, member of the Egyptian Urological Association, has a lot of publications. Main interest, laparoscopic surgery. He's a pioneer of single port.
Today I'm going to speak quickly about the laparoscopy in the era of robotic surgery. This is what I'm going to speak about. I have two parts of my presentation. The first part will be about the robotic surgery. I'm going to present when it started, what are the prominent players, what are the main propellers of the progress, and what are the main characteristics of robotic surgery. Meanwhile, in the second part, I'm going to speak about the conventional laparoscopic surgery, what are the capabilities of laparoscopy to persist in the robotic era, what are the observations from the real situation and from the literature, and do we really need to enforce the current position of the laparoscopic surgery in the robotic era. So first, I'm going to speak about the robotic surgery. Nowadays, we have the robotic surgery for more than 25 years. So the initiative of this was the intuitive who developed the first Da Vinci system in 1995. And the first robotic-assisted cholecystectomy was done in 1997. Then in urology, the first robotic-assisted radical prostatectomy was in 2001. And there was an FDA approval of the robotic-assisted radical prostatectomy in 2002. And in 2014, there were like more than 500,000 of patients who had robotic surgery by this time. Of course, nowadays, this number has been extended to many millions. Until 2019, it was exclusive only to intuitives to produce a robotic platform. By this time, the patents was expired. And what are the players behind the robotic surgery in our practice? All of these are the players, the companies, the devices, the surgeon, the societies, and the journals. So, if we look what we have nowadays, as I mentioned, the initiative was Da Vinci. Since the vanishing of the patency in 2019, we started to have new platform of robotic system. Some of them from USA, some from Korea, some from UK, Germany, and Japan. However, we should keep in mind that these new machines will face the challenge to achieve a complex goal of replicating similar outcome while aiming to more advantage and solve limitation, especially with the price. Also, with the new modalities, it's expected to do more complex technologies and actually to limit the complication that we have already with the current Da Vinci system. If you look to this table, this is the new modalities that are already approved compared with the Da Vinci. All of them are trying to do some modification regarding the degree of freedom, the scopes, the quality of the vision, and even some of them reduced the instrument instead of having 8mm instrument with the Da Vinci system up to 5 or even 3 millimeters. However, some of them have a lot of technical limitations. This is not approved yet, but it's ongoing. We have another system coming soon from Canada. It's a purpose-built for the robotic single-port surgery. And we have the Hugo system from Robotic. It's been used already in Europe, but it's not distributed worldwide. We have another system from Spain and another system from China. And for my knowledge, I know that there are still some new machines that will start to appear soon in the market. These are the societies that is behind the robotic surgery so far. The first one of this was the Society of Urologic Robotic Surgery. It belongs to the Indian Urologic Society, so it is from USA, and it's compatible with the European section of robotic urologic surgery. And we have also some societies that are standing behind the robotic surgeries nowadays. So, what are the rails of the progress? What are the main pillars of the robot? Compared with the conventional laparoscopy, we have the endorest, because with the endorest, to extend the hand abilities, we have wide range of motions, and this is mainly important for accuracy of the suturing and dissection for such difficult maneuver like radical prostatectomy. Also, there is a motion scale increasing that reduce the physiological tremors that we have with the conventional laparoscopy, and also bypassing the flaperum effect of the conventional laparoscopy. Also, with the robot, we have new modalities of vision. We have the 3D visions that allows more details of the anatomy, especially with the radical prostatectomy. Also, there is a patient and doctor enthusiasm. There is a false image about the actual role of the robotic surgery nowadays, and this results in what is called vicious surgery. We have the patient who is demanding robotic surgery, and we have the companies who are manufacturing the new machines and new version, and we have the hospital who are offering these new machines, and this is the way how to give this vicious surgery. So, what are the characteristics of this robotic era? We have many factors. The patient selection, usually the patient asks for the robotic, it's a new modality, so the patient asks for it, especially for the obese patient and patient with the previous abdominal surgery. Also, there is a disease selection. There is a tendency to use the robot with more complex and more larger tumors. There is a procedural selection. A robot actually allows better understanding of more the anatomy of the pelvis, and it revisits the old technique like the perineal or radical prostatectomy, and there is a new training program. Nowadays in the States, there is a part of the resident training program is to have training system and training program for the residents. And there is actually what is called telemedicine. If we think about the robotic surgery, it's not a real robotic surgery. It's a robotic surgery. The surgery should be done by the robot while you are staying at home. It's a robotic assisted surgery. It's a tool. But however, it allows what's called telemedicine. You can do the surgery while you are in other country with the guidance. You just guide somebody who doesn't know about the robotic surgery, but with this guidance, he can still do the surgery by using the robotic platform. So, in the center who are using still the conventional laparoscopy and we have the facility of the robotic surgery, it was found that there is a tendency to use the robot in a patient with larger renal tumor and in more complex renal tumors. So the surgeon also has a role. The surgeon behind is one of the players of this. So the surgeon, there is a shorter learning curve, there is a training program, there is shorter learning curve because with the robot, the surgeon is focusing more in the machine, not only on the technique. So this is shorted the training program, and the simulation is much easier with the robot than with the conventional laparoscopy. However, the surgeon started to have some problem like more local pain, especially with the closed console, the old one, more neck stiffness, and loss of non-verbal communication in closed console. So what this is about the robot, what we have so far about the laparoscopy. What are the capabilities that keep the laparoscopic urology still surviving nowadays? It's feasible everywhere, it's not expensive, especially it's at lower cost, cheaper development. So if you need to change a part of your system, you shouldn't change the whole system. You can have a new camera, this plate or whatever. You don't have to change the whole system like with the robotic surgery. There is a wide range of innovation, solution from many manufacturers. It's not limited to certain companies. We have a plenty of companies who are manufacturing the laparoscopic equipment. And nowadays, still, there is an essential need of laparoscopic skills to do a robotic surgery. So there is for preparation of the field, for docking, and for assessment. Still, you need well-experienced laparoscopist to do suction, to do traction, and to do clip applying. So by the end, laparoscopist can easily be a robotic surgeon, but not reverse. So if we look to the cost, you can just imagine that the cost of one robotic unit equal to from 25 to 30 laparoscopic units. It's a huge difference. If we apply this to the procedure, one robotic radical prostatectomy equals to two cases of laparoscopic radical prostatectomy. So this is very important, not only in our country, it's important worldwide. So, what about the outcome? The outcome is either procedure specific or not procedure specific. Like if it's procedure specific, it depends more in the technique. And usually this is reflected in some parameters like the ischemia type, partial nephrectomy, like the renal function, the continence, or the erectile function in case of the radical prostatectomy. If it's not a procedure specific, it is to some extent relying on the surgeon. And this is with experience, you can shorten the operative time, decrease your blood loss, length of the hospital stay, post-operative pain, and analgesic requirement, and the recovery. So, what we have in the literature to evidence whether the superiority of one of this technique over the other, the most strong evidence is either to have meta-analysis or to have randomized comparative studies. Unfortunately, in this field, the meta-analysis, there is a lot of bias, there is a lot of selection bias of the patient and selection of the procedure for different procedures. Regarding the randomized comparative studies, so far, instead, despite of having robotic surgery for more than 25 years, we only have 2 randomized comparative studies comparing between robotic and laparoscopic surgery. These 2 studies have very small number of the patient with a selection bias of the patient. And that was actually well reflected in the outcomes. So, if we look to the patient perspective, this is very important because the patient, this is a part of the problem of the application, because sometimes the patient comes to you that is convinced to do robotic surgery. To change its concept just to do randomized comparative study, this is non-ethical. So this is another one of the limitation and one of the problem for the application in this field. So far, if we compare between the laparoscopy and the conventional and the robotic surgery, conventional laparoscopic surgery is comparable to robotic surgery, for the renal surgery, prostatic surgery, and we will see this very soon in the literature, and the bladder surgery. However, the conventional laparoscopic surgery is much better than the robotic surgery regarding the cost of the procedure and the unit, the availability and the feasibility, realistic technical feedback, basic chance of the equipment malfunction, and the flexible management of the patient and assistant position. So, if you look to this table, it includes the most prominent studies worldwide comparing between laparoscopic and robotic radical prostatectomy. If you look to the intraoperative and post-operative outcome, you will find similar everywhere. So there is no superiority, real superiority of the robotic surgery over the conventional laparoscopic surgery. The same was found for the radical cystectomy, and again the same here for the partial nephrectomy. The outcome, whether it's intraoperative or post-operative, it's the same between the laparoscopy and robotic surgery. So far in the literature, we have 5 major meta-analyses comparing between, studying the published literature, comparing between laparoscopic and robotic partial nephrectomy. They did meta-analysis, univariate and multivariate analysis looking into different parameters. Regarding the operative time, all of them, they proved that, yes, laparoscopic partial nephrectomy could be an alternative to robotic partial nephrectomy. Regarding the ischemia time, there is a controversial data. However, the difference is so marginal. If you look for the rate of the complication, the majority, they agree that the laparoscopic partial nephrectomy could be an alternative to robotic partial nephrectomy. If you look to the functional outcome, I mean the GFR or the serum creatinine, yes, there is a lot of data about this. The only one who reported about this in favor of the laparoscopic partial nephrectomy. So if we look for the positive surgical margin, which is very important in cases of the renal tumor, here the majority they agree that the laparoscopic partial nephrectomy could be a safe alternative to robotic partial nephrectomy. So the blood loss, yes, there is an agreement that laparoscopic partial nephrectomy is comparable and a good alternative to robotic partial nephrectomy, and the same for the conventional. So the last issue is the length of the hospital stay. Yes, the majority they approve that the laparoscopic partial nephrectomy is a safe alternative to robotic partial nephrectomy. So just to conclude, regarding the current role of the conventional laparoscopy, conventional laparoscopy is an alternative and complementary tool for robotic surgery. Conventional laparoscopy is still the terminator of the majority of outcome of robotic surgery. In high volume center, with a high volume surgeon, still you can achieve comparable outcome between the conventional laparoscopic and robotic surgery, and better to reserve robotic surgery for specifically difficult demanding procedure to maximize the cost benefit, like patient with radical prostatectomy and patient with partial improvement. What about the future of the conventional laparoscopic surgery? Conventional laparoscopic surgery will persist as a viable and effective tool in the armamentarium of urologic surgery. Laparoscopic skills is valuable to any urologist or available for any urologist who will start robotic surgery. Laparoscopic skills are essential to assist in the robotic surgery. And finally, laparoscopy will remain an effective alternative to robotic surgery in situations that is you don't have the robotic blood flow. Finally, I would like to thank you again for the invitation and thank you for the question.